Dental trauma is a relatively common occurrence that is a concern for all dentists. General practitioners in particular should be prepared to provide treatment for dental emergencies that can often interrupt a schedule and require the dentist to provide quick and effective emergency treatment. Today, I would like to share with you the use of adhesive dentistry techniques to treat dental trauma by reattachment of fractured tooth segments. Adhesive techniques are commonly used in many phases of restorative dentistry, and I have listed several here. My focus today is not so much with definitive treatment, but rather with immediate treatment that a dentist can provide in the event that a patient presents with a traumatic injury. More specifically, I will focus on bonding of fragments of a fractured tooth, and in a future presentation, splinting of teeth that have been luxated or displaced from the tooth socket. Throughout this presentation, I will show diagrams such as this that have been taken from the Dental Trauma Guide, a collaboration between the International Association of Dental Trauma and the Copenhagen University Hospital. I have received permission for their use. First, let's define dental trauma. Simply put, dental trauma is a transfer of energy from an object to a tooth and/or the surrounding support structures. At a significant force of impact, the dissipation of this energy will result in the fracture of a tooth structure, the crown and/or the root, or the disruption of surrounding tissues as the stretching or tearing of periodontal ligaments or even the fracture of the alar bone. So today we will talk about using adhesive dentistry to treat these commonly occurring injuries. There have been many studies that have been done that have looked at the frequency of dental traumatic injuries, and there are a few points to keep in mind. About 80% of all dental injuries occur in the maxillary central incisors, given their prominence in the dental arch, and most of the injuries that occur to these teeth are uncomplicated fractures. In other words, fractures through the tooth, but not involving the pulp tissue. Most injuries occur in young patients, and it is estimated that 25% of persons under the age of 18 will sustain traumatic anterior crown fracture at some point. Finally, boys seem to be injured at a rate of 2 to 1 over girls. As you know, adhesive dentistry has been used for many years. Regardless of the generation of bonding agent or the brand that is being used, it all goes back to 1955 and is based on the concept of modifying the tooth surface and then using a resin that adhesively sticks to the tooth. Likewise, reattachment of tooth fragments also has a long history, initially done with conventional or non-adhesive materials, but in more recent years utilizing the resin-based materials that we commonly use every day in practice, making for a relatively simple and effective way to provide immediate treatment for dental trauma. The literature suggests that fragment reattachment has several advantages over restoration of the tooth with a composite resin restoration. You can appreciate the difficulty in restoring a tooth with a significant fracture and matching the shade and contour, especially a central or lateral incisor. All of these are valid considerations, but the last two listed here are particularly important. Most of the time, patients with dental trauma arrive at your office shortly after the injury and do not have scheduled appointments. This can be very disruptive to your schedule, but at the same time, we have a responsibility to see these patients and provide immediate treatment. Reattachment of the segments gives us a way to provide quick treatment that is functionally effective, cost-effective, and relatively quick. Obviously, the primary factor determining your approach to treatment is that the fragments need to be available to bond to the tooth. Ideally, reattachment is easier if the tooth has one broken piece that can be placed easily back on the tooth. However, even in the case where there are multiple pieces, and even if small pieces are missing, reattachment can still be a better option than placing a large restoration. So now that we are ready to bond the fragments back to the remaining tooth, we have a few additional questions to consider before we do so. How strong is the repair? And what technique and materials are best suited to reattach the segments? Let's take a look at what the literature says. This is based on an in vitro study that was published in 2001 that looked at different techniques to reattach the fractured segment. Obviously, all studies such as this are in vitro. Most people don't let researchers go around repeatedly fracturing their incisors. In this study, the researchers looked at 5 different ways of putting the piece back in place, and I have represented these in the diagram to the right. The first group was simply bonded with a resin cement. The second was bonded in the same way, but with a buccal chamfer. The third group placed an internal groove internally that was filled with composite prior to bonding. The fourth group had an over-contoured resin placed on the buccal surface. And finally, the last group had an enamel bevel placed that again was restored with resin. Their testing showed that the last 3 techniques restored the teeth to over 90% of their initial strength, with the last 2 techniques being statistically the same. Another study from 2010 looked at 3 of these techniques, but added the variable of using different adhesive systems and hybrid composites. Their findings were interesting in a couple of ways. Although they also found that the over-contoured restoration at the fracture interface afforded the highest strength, notice that the strength is a significantly lower percentage than the initial strength of all the groups when compared to the earlier study. However, one important factor to note is that the strength for all the groups were improved by using a hybrid composite resin in the interface or sandwiched between the segments, in addition to a bonding agent. Finally, let's look at one more study from 2010. Again, they studied 2 of the techniques that we've looked at already, but they also compared these to direct resin restoration. It's interesting in that they found no difference in any of the techniques, but did find improved strength by using a heavily filled hybrid or a nanocomposite. That makes sense. We know that there is added strength in highly filled composites. The other interesting finding is that the reattachment restorations and the direct composite restorations were comparable in fracture strength. Again, giving us a procedure that is potentially faster, likely to have better aesthetic results, and without a compromise in strength. In summary, most studies seem to suggest that a tooth is restored to approximately 50 to 60% of its original strength when fragments are reattached. The techniques that appear to provide added strength are those that incorporate a bevel or a chamfer at the fracture interface, with some overbulking of composite along that fracture line. Finally, bonding agents alone do not provide the highest resistance to subsequent fracture. Studies have suggested sandwiching a layer of highly filled composite, either a hybrid or nanocomposite, between the segment and the tooth to add strength to the bond. While we've answered these questions about fragment reattachment, several questions remain unanswered. For example, if there is not subsequent trauma, perhaps the tooth is sufficiently strong enough for normal function, even if it is not at 100% of its original strength. If this is a possibility, do we need to do more for this tooth, such as a crown or a veneer, or can the reattachment be considered a definitive treatment? We also do not know how these bonded fragments perform with time in the mouth and in normal functioning, since these studies are only done in vitro. Do they gradually lose strength over months or years of normal function? Regarding materials, we've seen that adding composite between the segments will improve their strength, but there is no research that compares different brands of composite, or for that matter, even different generations of bonding agents. How might an etch, rinse, and bond material compare with self-etch? Finally, we want the segments hydrated in order to take advantage of dentinal bonding, but we don't know how best to store the fragments en route to the dental office and how that storage may affect the strength or duration of the repair. In the future, we will review some cases and look at the clinical techniques more closely.